I'm going to press the record button, so please know that tonight's workshop on reclaiming pleasure, sexual health in women after cancer is being recorded. So before I begin, if this is your first time joining us, Cancer Support Community South Bay is a premier nonprofit organization providing emotional support, education, and hope for people affected by cancer and their loved ones. And we serve all of the South Bay, Long Beach, and Orange County, all at no cost to you. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs just like this one. And if you want to hear anything more about what we have to offer, I will put our website address in the chat box. But without further ado, I want to introduce to you tonight our workshop speaker. Dr. Mona Guo is a gynecologic oncologist, an assistant professor at Keck Medicine of USC, who treats all forms of gynecological cancer, including ovarian, uterine, and cervical. Her research interests are on strategies to enhance patient-provider interactions. So Dr. Guo, thank you so much for being here tonight. And we will go ahead and highlight you, and please go ahead and share your information and knowledge.
Thank you. Thank you for the invitation, and thank you all for taking time out on your evenings to join me here. This is a very big topic, and I'm gonna hopefully skim the surface of it, but just to make sure that you all know that this is something that your doctors, your caregivers should be asking you about and should be paying attention to. And it's not something that you should be ashamed of talking about and bringing up at your care, because it's part of your cancer care, it's part of your survivorship. And it's honestly something that we as providers and oncologists don't cover enough. But as a GYN oncologist, as earlier said, I do surgery as well as chemotherapy for my patients. And so I see patients throughout the spectrum of their care from early on until afterwards. This is going to focus a little bit more on GYN, so gynecologic cancers, and the ramifications of gynecologic cancers, but it's very relevant to other types as well. We'll hopefully have plenty of time for question and answer at the end. Our goals today are listed here. We're going to go over some of the common sexual dysfunctions that can happen after treating cancer, how these treatments can cause sexual dysfunction, what are the evidence-based strategies that we have for prevention, decreasing the risks, as well as treating. And I'm going to bracket these with some patients because patients are the ones who are going through this. So this first patient is a 46-year-old woman with hormone-positive breast cancer. She ends up getting bilateral mastectomy, sentinel lymph node biopsies, does end up getting reconstruction, and then gets adjuvant chemotherapy and radiation. She then goes on hormonal therapy. One of the common ones is Lupron injections, which we'll go over a little bit later for those of you who do not know what that is, as well as a daily pill, a hormone blocker called letrozole. Slightly different patient. This is a 55-year-old patient who is postmenopausal but has low-grade endometrial cancer, ends up getting a hysterectomy, which means she gets her uterus out, cervix, as well as ovaries, and then gets some local radiation to her vagina, so brachytherapy. She doesn't need any other types of chemotherapy or hormone treatment, but does end up needing speculum exams and pelvic exams every 3 to 6 months for the next 2 to 3 years, and then probably up to 5 years, and then annual. So for these two patients, 2 years later, they present with their partner to their surveillance visit. They both say that it feels like razor blades when they're trying to have sex, that there's glass shards in their vagina. Makes it hard for them to have sex and to be intimate with their partner. Tried over-the-counter lubricants, it just caused a lot of burning. And then their partner is scared of doing things because they don't want to hurt her. So as I alluded to earlier, sexual health really matters because it's part of survivorship and it's part of your quality of life. A lot of patients end up reporting sexual function changes during and after cancer, both men and women. For the breakdown there of the different gynecologic cancers as well as breast cancer, you can see more than 50% report some type of sexual distress or change. Also, when you have these sexual symptoms from a clinical standpoint, it can decrease the adherence of our patients to their treatments when the treatments are causing a lot more discomfort and problems, and then lead to increased distress, impacting mental health, your relationship with your partners, and yourself, and decreasing self-esteem. This was one of the larger survey-based research projects about breast cancer. So women who have been treated with breast cancer. There were, I believe, close to 1,500 respondents. Average age was a little before menopause, around 48. And 90% of the patients surveyed said that cancer diagnosis and treatment caused moderate to great deal of change to their sexual health. But more than 70%, so almost 3/4 of patients didn't receive any information about sexual health from their providers. And 70% of those who did end up discussing anything to do with sexual health had to initiate the conversations themselves. So the spectrum of sexual dysfunction, as well as the spectrum of sexual health, sexual function, is there's physical, emotional, there's social aspects. It's a whole host of different components and factors. We're focusing initially here on the physical ones. They're the side effects that we're more able to immediately see and immediately address. Sometimes they're the easier things to talk about. So taking a little bit of a step back, what are the treatments that patients with breast and gynecologic cancer end up getting? And how do they affect what happens to the female body? Well, with surgery, whether it's breast or GYN or gynecologic surgery, it ends up changing sensation. There's a lot of nerve damage and nerve reconstruction that happens. It affects our core sense of what a female body looks like and feels like. Right? These are the arousal organs. These are the organs that make some people feel like a woman. Can also lead to surgical menopause. Radiation, whether that's to the breast or to the pelvis, can cause menopause if it's to the pelvis. It can also cause the tissues to become very stenotic or tight. Specifically, this is in regards to the vagina. And then I'll show some pictures later, but because of where and all the organs that are in the pelvis, it can also lead to bowel and bladder changes. And then the chemotherapies can lead to surgical menopause. You can kind of see or the chemotherapies can lead to chemical menopause. So you can kind of see a overarching thing about many of the things that we do end up leading to a early menopause. Many of the chemotherapies that we give, because of how sensitive the ovaries are to medications, can cause a temporary menopause that's usually reversible. This happens often in breast cancer, but might end up leading to an earlier onset of when someone would naturally go into menopause. So a little bit about the surgeries. I do not perform any mastectomies or breast surgeries, but here's just a an overarching look at the different types of mastectomies. That's where your entire breast tissue is removed for the sake of treating cancer. The different types also remove different parts of the overlying organs. That's not just the breast tissue. So certain times the skin's removed, certain times the nipple is removed, and depending on what type of mastectomy it is, that reconstruction can happen at the time of that initial surgery, or it might need to happen a month or two later. And oftentimes with reconstruction, it's a stage procedure. So you're getting an implant placed first that needs to be adjusted before they can go in and complete it. For GYN, for gynecology, different types of hysterectomy can lead to different types of pelvic dysfunctions afterwards. But a hysterectomy, which means removal of the uterus, can be total, subtotal, or radical. I feel like a lot of us use hysterectomy, total hysterectomy, or subtotal hysterectomy in a very in a colloquial way, but in general, when there's a total hysterectomy, it means that the cervix is removed with the uterus. When it's subtotal, it means that the cervix is not removed. And then for the ovaries, it's a completely separate thing. Our fallopian tubes should be removed in all hysterectomies because you do not need your fallopian tubes if the uterus is no longer there. The tubes are there just to serve as a conduit for the egg to reach the uterus for fertilization. So if the uterus is gone, then there's no point of having a tube. Ovaries will only be removed if that oophorectomy is part of the procedure. And then the vagina should not be shortened in most hysterectomies. When it is with radical hysterectomies that's usually used to treat cervical cancer and sometimes some types of advanced uterine cancer. So the common treatments that we end up doing a lot of them are hormone-based. So for breast cancer, selective or tamoxifen is something that many of us have heard about, and it's commonly one of the more common medications that are used, mostly in premenopausal women because of the way that it interacts on the breast tissue as well as the breast tissue specifically. But tamoxifen can increase risk of uterine cancer, which is why people try not to use it, or oncologists try not to use it after menopause. Aromatase inhibitors are things like letrozole. So if you remember back to patient 1, she was on letrozole daily. This blocks testosterone specifically, but a lot of the estrogen that women get is actually converted from testosterone. So by blocking the testosterone being converted to estrogen, it can cause some and many hormone-related side effects. Usually postmenopausal women are who use letrozole, and it can cause bone density loss, so making the bones a little bit less strong because of that blockage of testosterone being switched. And then things like Lupron, which is that injection that that patient 1 used earlier, does end up causing chemical menopause. This is something that blocks the brain hormone, GnRH, which tells the ovaries to cycle their hormones. And so Lupron is also used in certain non-cancer treatments. So endometriosis is one of the common ones, as well as sometimes with fibroids, but this is reversible. It's most often used in premenopausal women, and it just blocks estrogen, progesterone, all of that. When our patients had said that there's glass shards in the vagina, that it feels like sandpaper, this is all encompassed in this broad name of GSM, or genital urinary syndrome of menopause. After the ovaries, or when we don't have estrogen in the female genital tract, so with the uterus or the vagina, there's just less blood flow. The vagina ends up being less moist, less supple, and ends up being dry. actually feeling like sandpaper is very apt because, as you can see from this cartoon here, you don't have these folds normally that you would see in a premenopausal vagina. And because you have lack of folds, you have lack of blood flow, it's much easier to cause cuts, to have bleeding, to not be moist and healthy. From the what exactly our anatomy looks like, I feel like we again, as physicians, don't go over anatomy as well as we probably should. This here is a side view of a female pelvis. So your legs are down here. This right there is the spine and the spinal cord. So the tailbone is over here. This is the bum. Belly, your belly button will be somewhere over here, and head is that way. That bone right there is the pubic bone, the bone that sits under the abdomen or under the belly. Underneath, we have the vagina that sits behind the urethra, which sits behind the clitoris, and then in front of the anus. So anus leads to the rectum, leads to the large intestines, the vagina leads to the uterus, and then the urethra leads to the bladder. All around this, with the muscles that you can see here, are the pelvic floor muscles. They attach from the pubic bone to your tailbone, kind of like a sling or a little hammock, about 3 centimeters above the entrance of your vagina. So the entrance of the vagina is down here, and 3 centimeters above is where this pelvic floor is. It holds all of the pelvic organs, and when you hear about pelvic floor dysfunction or people with prolapse, that's when this pelvic floor is weaker. They help generate core strength, support our organs, also helps with bladder function, so helps prevent or helps with incontinence, both bladder as well as rectal incontinence for bowel leaks or bladder leaks. When there's decreased blood flow to this area, so after menopause, the tissues are just weaker. There's also fewer good bacteria, bacteria is normal everywhere in the body. There's a bunch of good bacteria that live on our pelvic floor as well as in our vagina. But once we have less blood flow, there's fewer of that, which then can lead to just changes in the pH and the acidity of the vagina, leading to more dryness and irritation. The vagina can actually physically get shorter because it's getting not as elastic. And then the vaginal walls end up weakening. This entire pelvic floor weakens, which can affect bladder symptoms, can cause more recurrent UTIs, can also cause bowel symptoms. So for our more seasoned women, when there's recurrent UTIs as people get older, the one treatment that's been found to really work is to do vaginal estrogen, is to give a little bit of that estrogen back here so that the bladder health is better. So how can we affect or treat some of these genital urinary syndromes, so things that are affecting the vagina and affecting the pelvic floor? There is a lot of stuff over the counter, and if you've ever stopped in that at Walmart or at Walgreens or CVS and just looked at all the moisturizers out there, there are many, and a lot of them do have some data. So I'll go over this a little bit more in a table form, but moisturizers, better to choose those that are oil-based because they stick around a little bit longer, versus lubricants. And again, figuring out what you're using each of these for. Lubricants, they have water, silicone, or oil-based, and you use them differently based on whether you're using condoms, toys, or if it's just for sex. Can consider using topical lidocaine, so lidocaine cream. So that's a numbing gel that you can get either over the counter or prescribed by your provider that can help with that initial penetration pain. And then for these guys, if any of you guys have had radiation or vaginal brachytherapy, this would look familiar. But dilators can be used not just for radiation afterwards, but also when there's any type of stricture or stenosis. Many different sizes, they're made of many different types of materials, but they help to slowly increase both the blood flow as well as the caliber of the vagina. So talking about radiation here, radiation ends up as it's being given, shortening the vagina and causing more irritation. But then late effects, we call radiation that gift that keeps on giving, is that the radiation keeps on working on those cells to lead to more narrowing and more strictures. This is an MRI, which is a image similar to that cartoon we saw earlier where you have the tailbone back here. This is the pubic bone, and then you have the vagina leading to the uterus. The vagina there's contrast in there, which is why it's white, leading to the uterus, the bladder in front, and the rectum behind. Before radiation, the average female vagina is probably about 5 to 7 centimeters when it's not aroused. And then afterwards, this is 3 years after radiation, everything here just kind of shrinks down. So for anyone who's gotten radiation, using dilators is really important if you're not sexually active, to help with keeping that vaginal health and keeping that area more vascularized, so more blood flow to that area, so that exams afterwards can be easier, as well as intercourse and sex can be easier. So more into the vaginal moisturizers, oils, we said coconut, olive oil. There are suppositories with different vitamins. These are some of the commonly seen products that you have over the counter. A lot of them have the costs are very different, and their texture, the way that that different people have responses to them are very different. So try them out and see what you like better, what your partner likes better. Vaginal hyaluronic acid, so just like the hyaluronic acid that you've seen over the counter for face, like facial care, using it 3 to 5 times a week has been shown to improve symptoms of dryness. And even compared to estrogen, there's some data to show that using hyaluronic acid, if you can't use estrogen because of cancer reasons, has I think 91% of patients who use hyaluronic acid had an improvement in their genital urinary symptoms of menopause versus like 95% of those who use estrogen. So pretty good. Lubricants. No. Looks like my screen froze here.
If you want to try to stop it and reload it, if it's not forwarding. There we go. Perfect.
We just had to talk about it. Lubricants, I was saying that it depends on what you're using it for, because the different types of lubricants can't be used with certain things, especially with silicone things. Specifically, silicone can't be used with silicone. So if you have toys, dildos, vibrators, you can't use a silicone-based lubricant because it will destroy your toy. Oil-based things can't be used with condoms. It will make them ineffective, can cause damage to them, similar to damage with the sex toys. So having various lubricants for various reasons is helpful. Importantly, petroleum jelly, so Vaseline, should not be used as a lubricant. It's something that a lot of patients use. A lot of my patients have said that they use it because it's available, it's cheap. But it doesn't really actually help. And oh, there it is. I did have a little thing there. It ends up causing more irritation, even though at the time of using it, it might seem like it's adding some lubrication. But Vaseline doesn't. It doesn't lead to the same type of friction improvements as the water or silicone oil-based lubricants, and can actually cause more irritation.
Do you mean in that top box, do you mean irrigation or irritation?
Irritation. Oh, thank you for noticing that. Yes. So vaginal estrogen, this is the reason why this is all happening is because the vagina doesn't have enough estrogen. And so it makes sense that we can just give some estrogen back to the vagina, and then that will help. So these are all prescription based. Vaginal estrogen, there's two main brands, Premarin and Estrase. Those are the creams. They usually come with this little tube that you would use to put different amounts inside the vagina. Costs over the counter are vastly different. I think Premarin, when I just looked now on GoodRx, is actually $200, but Estrase is now $200 too. Cost Plus Drugs is a separate site run by Mark Cuban, but this often has a lot of cheaper options. They're generic options that you just need a prescription for. So for Estrage cream, it ends up being $13 when I checked on there last night. A lot of insurances should cover these things when you have proven or have a diagnosis of vaginal dryness, vaginal irritation, recurrent UTIs, surgical menopause, any of those things. I often tell my patients not to use the included applicator, especially when their vaginas are a little bit more stenosed or irritated already, because this is a plastic tube. It's sometimes hard to clean, but it's hard to tell how deep to go, and you can also actually cause some irritation just by putting the tube inside the vagina. You can just put some on the finger, like use it as the cream comes out as looking like toothpaste. Just put some on the first segment here of your finger, and then any of it going in the vagina is fine. It doesn't have to go in all the way. There's also vaginal inserts. Some patients like these more because they're easy, they're cleaner. It's a little tablet, or sometimes it comes in a little insert, which goes in the vagina with different doses. Prices are also vastly different, again, depending on what your insurance covers. And then selective estrogen receptor modulator. So this is a pill, Asfina. It is still relatively expensive. It's a once daily pill that specifically targets the vagina. There's also some emerging data of using lasers or radio frequency devices. So some of the med spas might talk about having different types of laser treatments, whether it's CO2 laser, the Mona Lisa. There's some data with it, but the issue that we see from a clinical standpoint is that often the providers who are giving these treatments are not, they're often not OBGYNs, they're often not people who are well-versed in women's health. And so it can cause more damage. So to use with caution and make sure you know who you're getting these treatments with. Big elephant in the room is if you have breast cancer and you have a hormone positive breast cancer, can you use vaginal estrogen? There's actually no real good data. There's actually no data behind this. Nothing that it has been looking at this question prospectively. There's a lot of studies looking retrospectively, which means we ask patients who have had breast cancer, who also have used and didn't use vaginal estrogen, whether there was any difference, and to look at their charts. And those studies have shown that there was no change in recurrence risk, and ultimately actually decreased mortality, which means decreased death. Why using vaginal estrogen might decrease death, no idea. But what guidelines just recommend discussing with your oncologist. And many oncologists are comfortable with breast cancer patients, especially if it's been years or with the degree of symptoms, for using vaginal hormones. Since the amount of hormones that goes in that gets absorbed inside the vagina, that then goes to the breast or goes anywhere else, is extremely low. For endometrial cancer, so people with uterus cancer who also are often hormone positive or hormone sensitive, for those early grade, early stage uterine cancers, so where you treat them with a hysterectomy and then that's that. I feel completely comfortable giving my patients vaginal estrogen in those cases, and most GYN oncologists would feel comfortable with that as well. So for those two patients we talked about earlier, they ended up getting this discussion about choosing different types of vaginal creams, vaginal estrogen. They do end up having improved vaginal dryness, but still feel that deep penetration pain, and still feels that they just don't have a desire to have sex. Also a difficulty to achieve orgasm. So you've treated the physical symptom of vaginal dryness, but not really the rest of the things that come along with a sexual relationship. It's also important to note for the breast cancer patient, after a mastectomy, depending on what type of surgery she had, her skin and nipples might be gone. And then for some patients, that's a huge part of arousal. And so you lose that sensation. So there is a label for this. And for some patients, it's helpful to know that there is a label for this for hypoactive sexual desire disorder, where it's not something that's a physical thing that we can point down to why this is happening, but more of something within this spectrum of what a healthy sexual life is. So now we're looking more at therapies, not just therapies like talk therapy, but actually physical therapies too. Pelvic floor PT for almost all of my patients who've had cervical cancer, certainly, but a lot of GYN cancers, once we're into that survivorship phase, if they have problems with their pelvic floor, pain with penetration, pain with intercourse, incontinence, this retraining those pelvic floor muscles can make a huge difference. A good pelvic floor physical therapy is really hands-on and not just looking at how you're working, but physically feeling those muscles. Sometimes it involves putting their hands within the vagina or on the perineum to feel so that you know how your muscles are reacting. Can use dilators or toys as part of that sexual encounter. Part of this is discussing with their partner about how to regain those things that make you aroused. And that might include certain exercises to figure out how might be more of a step-by-step thing as opposed to previously when you have this sudden desire. And then the talk therapies of couples counseling as well as cognitive behavioral therapy, which none of these are isolated. They can all be used together. There are medications now. Really in the past 5 years, we've started having medications for women for sexual desire. This is if other reasons have been ruled out. This was the first one that came out. Agi, it's a daily pill. They had a study looking at breast cancer patients. I think there were 30 some patients who were on this, who were already on hormone therapy, but still had hypoactive sexual dysfunction. And they, using this for about 4 months, did have improvements in desire, arousal, and lubrication. But then once they stopped using it, it stopped working. It also did improve their sleep from 6 to 7 hours. This is a different one by Leslie. It's injectable and it's mostly used for premenopause. Again, both of these are for premenopausal women. There are certain depression and anxiety medications that can be used off-label, the most common one being bupropion or Wellbutrin. And then testosterone can also be used off-label in postmenopausal women, specifically for increasing sex drive. So then those two patients, 9 months later, they've both report satisfaction with their sexuality. They've started Wellbutrin. They started working with different types of therapies and started counseling with their partner. And 9 months is a long time to see change. And I think your cancer treatment can often take 9 months. And so to think of all the things that are happening to you during those months and the slow changes to your body that are happening as you're getting treated, getting back to normal is going to take just as long, if not longer. A little bit of a side, different direction here, and talk about a younger woman who had advanced cervical cancer, ended up having a fistula, who's having, which means it's an abnormal connection between two organs. In her case, she had a fistula from the cervix, or where the cancer was, into the rectum. So she ends up getting a colostomy, which is a diversion. So her colon now comes out to the skin and the poop comes out in the bag. She gets chemotherapy, gets radiation, and is cured from her cervical cancer. But she, with all of that stuff that we ended up doing with the colostomy, with radiation, she's in surgical menopause. She's in radiation-induced menopause. She's 36, she's 38, she's having all these hot flashes and mood swings. She can't go back to work. She hates her ostomy. She doesn't know what to do with it, doesn't want to go out, and just can't have sex with it. I put the star on there because this is also a common thing that we see in rectal cancer, especially with those patients who have those really low rectal cancers that can cause fistulas within the vagina. So iatrogenic menopause is just the way that we say it's menopause that's caused by something that leads to the ovaries not working. Can be surgery, can be chemotherapy, can be radiation. When we typically go through menopause, so between the ages of 45 to 55, in the US on average, it's about age 52, it's a slow decline of that estrogen. These symptoms happen over years. When this happens from cancer treatment, it's all of a sudden. And it's hard to really prepare someone for that. For patients who get certain types of cancer, so the cervix and for the rectum, about half of them, or for gynecologic cancer specifically, so uterus cancer, cervix cancer, about half of them are younger than 50. And for colorectal cancer, about 10% of the patients who get those cancers are premenopausal. So in these cases, if your ovaries don't work and you're no longer getting the estrogen, the first thing to think about is to give that estrogen back. Something that I have found that is missed a lot of the times when patients end up not seeing an OBGYN or not seeing a GYN oncologist, a young patient who ends up getting radiation, who ends up getting treatments, and then are just hot flashing away and no one's ever really talked to them about it. Hormone replacement is almost like a magic bullet in those cases. Candidates for systemic, so that means hormones that go throughout the body, so not just local in the vagina, but something that your entire body ends up getting. The general guidelines is that if you're younger than 60 and fewer than 10 years since menopause, you'll be a candidate, especially if there's bothersome symptoms. There has to be no contraindications to getting the hormones though. And those contraindications, some of them are listed here, breast cancer risk being a large one. And it should not be used purely for preventing coronary artery disease, so preventing atherosclerosis or preventing heart attacks, preventing chronic diseases, preventing bone loss, or preventing dementia. So the hormone replacement is used because you have symptoms, not because you want to be preventative. And again, to discuss with your medical oncologist, the person who's treating your cancer, to make sure that they're aware you're using this and that they agree. This is a busy page, but it goes over a bunch of different types of cancers and where hormones are okay. And you can see that it's many of them that giving systemic hormones, so being on hormone replacement is fine. Up here we have breast cancer. So triple negative breast cancer, those that do not respond to hormones. This is still, I think if you talk to a lot of breast doctors, you're going to get a very vast array of different opinions. Some people say it's completely fine, that if you're hormoned, if you're menopause symptoms are that bad that there should be no reason why giving hormones is dangerous when your cancer does not respond to hormones at all. Other providers say to wait for the 2-3 years where the highest risk of recurrence is before you start hormones. And then other people say, no, not at all. Cervical cancer, almost always okay. Same with vulva and vaginal cancer. Uterine cancer, depending on the type. Same with ovary cancer, depending on the type. But the most common ones, so the high-grade serous ovarian cancer, completely fine to get hormone replacement. Thyroid cancers, liver, pancreas, melanoma or skin cancers, colorectal cancers, kidneys, lymphomas or blood cancers, head and neck cancers. All of these ones have been found safe for use of hormones. The avoid ones are pretty few, and these are the ones where we would treat you from a cancer standpoint with anti-estrogen or anti-hormones. So many breast cancers, you end up getting medicine treated, you end up getting chemotherapy or pills or shots that block hormones. And so then it wouldn't make sense to be giving hormones back in those cases. Same with certain types of ovarian cancer, and then certain types of sarcomas or muscle tumors. And then there's just not much data in some other ones. So what exactly these systemic treatments are, the most common thing that we use is the estrogen patch. This is what one of them would look like. It's a little sticker that you would put on your belly, arm, your butt, that is switched either weekly or twice weekly. They also have gels or pills. If you have a uterus, you have to use it with progesterone, because just using an estrogen without progesterone can cause uterus problems and can eventually cause uterus cancer. You can also continue low-dose birth control pills. Gabapentin is a common medicine used for pain as well as nerve pain, post-operative pain, but it does off-label works great for hot flashes when taken at night. And then certain antidepressants, so Effexor, Paxil, those are the common ones. And then non-prescription. I'm not going to get into a lot of their integrative and complementary medicines here, but there is good data for things like using acupuncture to treat hot flashes and menopause. There's also data for melatonin, for soy, for all of these. But again, make sure you and your oncologist and your cancer physicians and providers are on the same page with what you're doing. Briefly, for testosterone, we generally don't recommend this. Using testosterone with estrogen, progesterone hasn't really been shown to change anything. And when you end up finding providers out in the community who end up saying that they're going to give you bioidentical hormones, it really just means that they're giving you hormones that look the same as what your body's own hormones produce, but it's very unregulated. Bioidentical regimen is really a misnomer, because the medicines that are these commercial medicines, they're unregulated, and their goal is to replace them to a normal premenopausal woman's range, which is not where anyone should necessarily be. So it is complicated, and you should be getting active monitoring of your hormones if you are if you are getting these type of custom hormone regimens. I do like to note that virtually all the estrogens you end up giving people, or that are out in the market, are natural. They're from plants, or from Premarin is from the urine of a pregnant mare, is how it was first created. But they are technically all natural. The star here about testosterone was that specifically it can be useful, and it is useful for libido. So that patient we talked about, the young lady with the fistula as well as the ostomy, she started a hormone replacement, ended up getting diagnosed with vaginal stenosis and doing all of the things we talked about earlier. They ended up doing some more surgery to get rid of scar tissue, and then joined a support group with other patients who have ostomies, to know that it's something that we can live with, and that patients have figured out how to make part of their lives. I'm just going to end here with a lot of this being empowering you guys to advocate for yourself. We, as I said earlier, as providers, do not do a good job of asking about it, and often just don't know enough about it. And for us, there's a lot of reasons why we don't end up bringing it up. Oftentimes it's because we don't want to bring it up because we don't know what to do. And if we ask and you tell us and we don't have anything to give you, it's, you know, as physicians and as caregivers, we don't want to not be able to provide help. So not a reason why we shouldn't be talking about it, but it is a common theme. And then time as being an issue for everything to do with modern healthcare. Here are some ways to bring it up that might give a little bit, make the conversation a little bit easier. And it's something to just bring up a little bit at a time. It's not something that I think if your provider doesn't feel comfortable with talking about this, then ask if there's someone that they would recommend that you do talk about this with. There's a bunch of other considerations, which I do not have time to go over here, but is important and is different depending on the group of patient that is experiencing them. And there's a lot of other dynamics that come into play, both medical as well as social and emotional. And then use the communities, the supports that are, or the resources that are out there. Here are just some of them. Cancer support is fantastic. There is a online support group specifically for sexual health that I have sent some of my patients to, and talk about it. A lot of this is bringing it up more so that your friends, your family, the cancer patients around you know that they're not going through this alone either. But thank you guys.